People that know me well would find it very funny to see me presenting an innovation event. I've spent most of my life complaining about people that come in with the next big fix, you know, the next big idea. I have spent all my career working in health systems strengthening, health supply chain strengthening specifically, and frankly we kind of know what works, and it's not the quick fix. It's just good staff training, ongoing professional development, adequate infrastructure, sufficient financing, contextually appropriate procurement documents, really exciting stuff like that. But if you can get good people doing those boring jobs well for a long time and support them, they work. And we see that again and again. And the problem with the next big thing is that people come in and it pulls attention away from the boring work, and it pulls funding away from it. And because the next big thing usually doesn't work, critics come along and say that A, doesn't work, and that pulls money out of the whole sector. And so it's affected our careers as we've gone along. So the question is, how am I standing up here in front of all of you at an event like this? 18 years ago, I was studying pharmacy at university and planning to follow my parents into the wonderful primary healthcare profession of community pharmacy. And when I was in second year, a really good friend of ours, a guy called Matt Peck, was travelling in South America, and he had a freak accident. He fell, he hit his head, and he drowned in a river. And in his memory, we set up a travelling scholarship, an opportunity for one pharmacy student each year to go and work in a developing country's health system over their summer break. The Matt Peck Scholarship is now in its 16th year. It's been an enormous success, and I was its first recipient. And that's how, in the summer of 2004, I found myself in Vanuatu working with an amazing pharmacist, Amanda Sandberg, and the Vanuatu Pharmacy Division. Not because I had any interest in a career in international development. I was just trying to sort of honour the memory of a mate, and this was a great way to do it. And for the first 2 weeks, I did exactly what you would think I would do, which was drink a lot, hang out with the volunteers and the med students, and generally have a lot of fun in Vanuatu, and work 9 till 5 and learn a lot. But I had not changed my my career plans by any stretch of the imagination. And in my third week in Vanuatu, through some weird coincidences, I got sent to run the hospital pharmacy in a little provincial hospital in Noosa, in Malakula province, on my own. So I was supplying medicines to all of the clinics in the province, dispensing to outpatients, filling ward impress cupboards, and scared out of my mind. I was 21 years old, about to go into fourth year uni. And I was scared out of my mind, literally living at the hospital. So living like in a patient's room in the hospital, using one of the showers on the wards. And in my second week there, a young boy was brought in suffering from diarrhea. He had been poorly managed at the clinic for whatever reason and had presented on it about his third day. And I watched as a local doctor tried to get a line into him to run IV fluids. And he didn't have the right equipment, and even if he had, it probably was too late anyway. The little boy was really badly dehydrated by the time he arrived, and he died that afternoon. That was like a gunshot moment for me. This was a boy dying from diarrhea, about a 2-hour flight from Brisbane, and something went off in my head. By the age of 24, I was the chief pharmacist of Solomon Islands, and I've worked in international development ever since. The treatment for diarrhea in children under 5, we know quite well. Other than oral rehydration salts, the number one treatment is a drug called zinc sulfate. Now, zinc sulfate's a great drug. Given orally, very few side effects, reduces the severity of disease, reduces the risk of recurrence, heaps of evidence to support it. It's a great drug. In 2009, we introduced zinc sulfate into Solomon Islands. So got it onto the essential medicines list, got it financed, procured it, brought it into the warehouse, and then waited to see what would happen. Very, very proud of ourselves. In 2011, we did a study on the availability and the usage of zinc sulfate across primary healthcare facilities in Solomon Islands. And it was terrible. It wasn't really available anywhere. It was available in a few clinics. It was barely being used. The whole thing was on the brink of disaster. There was almost no point in having zinc sulfate. But what the study really showed us was not that we didn't know where the zinc sulfate was. We didn't know where the facilities were. The facilities were not where we thought they were. The names weren't the same as what we thought. We didn't know which ones were open or closed, which staff were working there, what services they were supposed to provide, anything, whether the fridge worked. And I sent an email to a colleague in 2011 with another couple of catalysts, like people asking us, could we fix a clinic in Western Province? But they couldn't even remember the name of the clinic. Saying, wouldn't it be great if we had a platform where we could see the health system that we're supposed to be supplying and see what's going on in something like real time? And wouldn't it be great if we could do this across a whole string of Pacific Islands? Laugh, laugh, laugh. And by 2012, we had turned that into a proper idea, and we floated it around and didn't get any traction, and kind of put it on a shelf for 5 years. I went away, did my PhD on using tablet computers in health facilities to manage stocks, left the Solomon Islands and was in Timor when Innovation Exchange came along, and started asking for ideas of how to deliver aid more effectively using innovation. And we had a 5-year-old idea kind of in the barrel, so to speak. We called it Tupaia. So Tupaia is a health data aggregation, analysis and visualization platform. So what does that mean? Well, we pull data from existing data sources. So stock management software, where it's being used, health information systems where they're available, live fridge temperature monitors, and our own data collection app, as well as other sources, to provide a real-time map of health services across the region. Today, Tupaia is available, or is tracking 700 facilities across 6 countries. We have over 700,000 data points. Through our app, we've collected over 35,000 clinic-level surveys. And we use that to build a picture for specific user groups interested in specific needs. So how does that manifest is probably the most obvious question that we get asked. So in Kiribati, for example, we use heat maps. We sit down with the National Pharmacy Division and use heat maps of medicines availability to plan their annual touring for the year so that they can concentrate on the areas of most need. In the last 12 months alone, medicines availability at the primary healthcare level in Kiribati has increased by 22%. In Tonga, down at the health facility level, we can track the aggregate results of all diabetes tests, so HbA1c results down at the primary healthcare level, to again focus on areas where we're not seeing improvement in services. In Vanuatu, we've just launched a pilot a month and a half ago with an immunisation module that allows us, amongst other things, to look at live feeds of fridge temperatures. And in the last 30 days, we've been able to spot 2 breaches of fridge temperatures and see that one of them was just a minor blip. Probably someone left the door open for too long. But one of them, the fridge is broken. And so that the local EPI coordinator can target that facility without having to tour around to every facility, which saves time and money. And of course, in Tonga, as the Minister very kindly pointed out, we've also used it for disaster response. Maybe most excitingly for me, across every facility in the Solomon Islands now, we can track the availability of zinc sulfate. And in 50 of those facilities, we're doing that in real time with tablet computers down at the facility level. We've now also very, very fortunate to have received a 3-year funding grant from the Centre for Health Security, which will allow us to build out and maintain the platform with a focus on disease surveillance, disaster response, antimicrobial resistance, and a couple of other things. From there, I mean, obviously we would like to cover the entire Pacific with Tupaia and move into areas that probably outside my realm, education, infrastructure, those sorts of things. And we're able to do that because Tupaia is available as a completely free and open source platform, available to anyone who wants to use it with no licensing fees. See, Tupaia was a real person. He joined Captain Cook's mission in 1769, and he helped the Europeans, with all their innovations of the time, map the Pacific better than they could with those innovations. But Tupaia died in Java in 1770, and we think that too many Pacific Islanders have died unnecessarily. And if our innovation can help Pacific Islanders do those boring jobs more effectively, then Tupaia and Matt Peck and a little boy in Norsep won't have died in vain. And that's something that we're incredibly lucky to be able to do, and profoundly grateful to DFAT for giving us the opportunity to do. Thanks very much.